Hi everyone, I'm Nashwa Abdulsalam with Heart Rhythm TV, and I'm joined by Dr. Sundaram. Welcome.
Thank you.
We are here to discuss one of the late breaking clinical trials that transform AFib. And we know that GLP-1 receptor agonists have created waves in heart failure, preserved ejection fraction. They're currently indicated in patients with type 2 diabetes and cardiovascular disease or at risk of cardiovascular disease. So the question is, can this extend to AFib? And that's what the study sought to answer. So can you give us a quick summary of the study and its results?
Yeah. Thank you for having me here. So the whole premise of the study is that the residual risk of AF, even post-ablation, is not trivial and it's quite significant, almost 1/3 of them having recurrence within a year of follow-up. And one plausible reason for this high residual risk is suboptimally managed cardiometabolic risk factors, and obesity is a predominant driver in the Western population. That was the premise of the study, where it's a pharmacoepidemiological study across the entire Veteran Affairs health system, where we investigated the relationship between GLP-1 receptor analog use and the burden of atrial fibrillation in patients with pre-existing AF and obesity. So what we observed was a 13% reduction in the AF-related events with GLP-1 receptor agonism, and compared to a comparator group. And even when we modeled for the competing risk for mortality, we saw that the reduction in residual risk did persist in terms of hard AF-related events, that is AF-related procedures. Yeah, that's it.
And what implications do you think this study is going to have on the future?
Yeah. So while almost for all therapeutics, in the absence of randomization, we should view the findings as hypothesis generating. Like this is a pharmacoepidemiological study. We should view this as hypothesis generating. But a feasibility of randomized trial in this way, all of us would be quite challenging, as we'll have to randomize patients who are obese with AF to a control group with no GLP-1 receptor agonists, which would be quite challenging. And because we are modifying a risk factor and looking for outcomes, that would mean it would be a long-term follow-up. And even if we randomize for long-term follow-up without preventing crossovers, is going to be not easy. So it's hence we are depending on studies, including this, the pharmacoepidemiological studies, why we would prefer a randomized trial to change guidelines. So this actually is it throws the idea of almost half of the patients in the United States who undergo AF ablation have a body mass index of greater than 30, and it's suboptimally managed. And we should consider managing obesity along with, it's not to replace procedures, along with managing atrial fibrillation through ablations and drugs. This should also be part of the management, and use obesity as an indication to co-manage this, or consider using GLP-1 receptor agonist along with the conventional therapy for AF.
Yeah, it seems like we always come back to risk factor modification, which is a very strong part of the guidelines. And so, yes, this is a really important point. Anyways, thank you for the summary and for the insights. Our viewers continue following us for more coverage of HRS 2025.